Start recording. Perfect. Thank you. And I'm going to turn it over to you guys.
Hey, hi, everyone. Welcome to the Clinical Nurse Specialist Advisory Committee meeting, January 16th. Our first item on the agenda is item 1.0, call to order, roll call, and establishment of quorum. Elisa Brown.
Alyssa Brown, I'm here.
Okay, good. Carrie Krogan.
We're not able to hear you, Carrie. Can you come off mute? And then board moderator Reza's in the attendees if you want to elevate him, please.
Carrie Krogan in attendance, eating lunch. Sorry.
Okay, Shannon Buckley. Okay. Marilyn Abayo. Okay. And Loretta, do you want to talk a little bit about Marilyn?
Wait until she's able to come on and introduce herself when she gets started. Marilyn will be our new public member.
Okay.
Okay. And then Jessica Lightcap here. So we have 3 of our 4 members right now present in the meeting. So we have established quorum.
Okay, before we go on, can I have board moderator, can you please elevate legal counsel? He's in the attendance. Okay, and I am here, Loretta Melby, or Lori, and I'm your board's executive officer, and Reza Pejuhesh, our board's legal counsel, just showed up as well. So we are here and ready to begin. So we can go into item 2.0, Mark, or board moderator, sorry.
And remember, this is the short version.
Yes, we do.
Good afternoon. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. When the committee reaches a point in the agenda at which public comment is appropriate, I will provide instructions on how to use the WebEx question and answer feature. We will also query the in-person location for any public comment. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute your microphone automatically. Thank you.
Okay, moving on to item number 3.0, public comments for items not on the agenda and items for future agendas.
We will be opening for public comment item. Oh, sorry.
No, that's what I was going to say.
Oh. All righty. We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and will move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Lightcap, there are no public requests for comments on the WebEx. I am informed that we have no public representation yet in our hearing room, so there are no requests for comments there. Would you like me to close this window?
Yes, please. Okay. Moving on to item number 4.0, review and vote on approval of previous meetings minutes. The meeting was item number 4.1, August 15th, 2024.
I move to approve the minutes. Alyssa?
Thank you. Do I have a second? I can second. Jessica Lightcap.
I keep forgetting to unmute myself. Carrie Krogan was seconding, trying to at least.
Okay. Now we would like to go out to public comments.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no public requests for comments in our physical location in the hearing room. Would you like me to close this window?
Yes, please. Okay, and now we will do a roll call vote for the minutes for our committee members. Alyssa Brown,
Yes.
okay, Carrie Krogan,
Let's approve.
okay, Jessica Lightcap approved. Okay, item number 4.0 is closed. Moving on to item number 5.0, discussion and possible action, report from the 2 CNSAC subcommittees, public engagement and website, and regulations. Regulations, you want to go first or second?
We can go first. It's all right.
Okay.
Alyssa, please feel free to hop in
I
on
will.
anything. We do have some draft regs that we have adapted from the regs put together by the California CNS committee, I guess it's called.
California
They do-
Association of CNSs, yeah.
Yes, association, thank you. They do very much resemble the nurse practitioner definitions and regs that have already been approved by the board. So we do have sections on definitions of what a clinical nurse specialist is, you know, the 3 Ps we have to go through: advanced healthcare assessment, talking about curriculum changes, education programs, you know, all of those definitions. We do have a section on categories of clinical nurse specialists that do fall in line with AACN and
The consensus model and.
thank you,
actually-
this model. I apologize.
What
Head's
we've
not
had
in it.
before, and you'll note that we put the word include because there may be other categories, so we didn't want to have to go back in and change that. So it says include.
Correct. We do have a section on the requirements for certification as a clinical nurse specialist, meaning we have to have a master's degree and either national certification or successful completion of a CNS program that's approved by the board. I know, from what I understand, we are the last state that is allowing CNSs to not have national certification. And then also it does discuss what graduates from foreign countries that they shall meet the requirements as well. It does go over the evaluation of credentials and the application process, and also the requirements for clinical nurse specialist education programs in California as well. We have a section on requirements for reporting clinical nurse specialist education program changes to the board, and then a whole section on actual clinical nurse specialist education, what the requirements are for administration and organization of the programs, for faculty, directors, clinical preceptors, what the education program curriculum needs to entail. And then we do have a section on scope of practice that nothing in our draft regs would limit our current RN scope of practice. Then we do have a section on requirements for clinical practice experience for the CNS students enrolled in non-California based CNS education programs. And then at the very end, we have kind of a notice to consumers that we adapted from the NP regs as well. So currently, I believe these are being looked at by DCA legal, right? And making sure that we have statute that will support the regs that we are putting forth. So more work to come.
Yes, much more work to come.
That's all I got.
Much more work to come, huh?
Much more work to come. So just to give you guys an update from BRN side, they have not made it to DCA legal yet. They were reviewed by Marissa Kark, our chief of ledge, and they are currently in my hands. And I am reviewing them. I do have some questions that I'd like to put out to the subcommittee to potentially maybe vet with the organizations and see if that's some place that you guys want to head to. So the one is we have you guys have submitted extensive regulatory oversight for educational programs. We did reach out to DCA Regulatory Legal. They said that we could move forward with that in statute. However, that's not something that we have done to this extent in the past. And so I'll give you guys some history. In the past, what happens with CNS programs is they are not required to have BRN approval to operate in state. We do know about them, and we currently have a process called Method 1, which allows CNS students who graduate from the California programs to become licensed in California without national certification. Obviously, that's something we're going to have to codify in regulation to move forward and continue with that process. It does follow the process that we do have outlined for nurse practitioners. The aspect of that would cause a change throughout the academic settings in California is if we were to move forward with this in regulation, that becomes a requirement that the schools do have to get California approval. That has been an optional thing that they have all sought out. So I don't know that they would complain or say this is something we don't want to do, but I want to bring that attention out there to the public, to the subcommittee, to this advisory committee to consider that. If we do not move forward with doing a formal approval on these schools, we have a couple different pathways. One of those pathways is to remove Method 1 for licensure, which is to be licensed without national certification, right? And because the way that we utilize Method 1 in California that we would have to codify in these regulations is you come from a California board approved program, right? If we're not going to do a California board approved program, Method 1 would go out. We would only license on receipt of national certification. And that would be a path forward very similar and would mirror probably the nurse anesthetist. The nurse anesthetist right now, we do not approve their academic programs, and they are only licensed in California based on national certification. If we choose to move forward with regulations that would allow for CNS programs that are approved by the Board of Registered Nursing to have their graduates licensed through a Method 1, there is a process that I shared with the CRNA group this morning where that remaining state that was not us just adopted, I believe, this last legislative session, where they allow for licensure, an interim kind of APRN licensure for 6 months while they work to obtain their national certification. If they attempt their national certification and don't pass, they are able to repeat that in that 6-month time period. And we do not remove the ability for them to work on that interim license. If they fail a second time, we would consider, if we put this into regulation, to remove that interim license because they would not meet national certification and therefore would not go forward until national certification is obtained. That's a process we can consider. If we move towards that process of continuing to license in California without national certification, what would have to change with our process that we're currently doing right now is that we would then have to do a scheduled review of these schools. Previously, what had occurred is you were reviewed once, and on review of one time, that kind of stuck. That is not the process that we do currently. Our pre-licensure nursing programs are reviewed on a 5-year basis. Unless they're nationally accredited, then we follow the accreditor schedule. With the nurse practitioner programs, they must be nationally accredited in order to get BRN approved, and then they follow that review process as well, where there is a routine ongoing scheduled review so that we can ensure that all the requirements continue to be met. So there will have to be a change of some sort within the CNS academic approval, but I want you guys to be fully aware of the impact of both ways. If we choose not to have our academic programs approved, there would no longer be a method 1. If we choose to have academic programs approved, that would be a change. We would have to continue that process and schedule out a routine follow-up, and then use very much the regs that you guys submitted, because you guys did mirror a lot of the nurse practitioner regs, which do require that ongoing review. Any questions, comments? I did see Alyssa's hand go up.
Yeah, all right, so when we talk about approved programs, are we talking approved by the BRN or by some other body or some national body, or either or? And
So that would be up for consideration as well as we're developing these regulations and fleshing them out. NP programs require them to be accredited first, and then they follow with BRN approval.
okay,
We then, for BRN, defer primarily to the accreditors. If you lose accreditation, you lose BRN approval.
mhm,
That is what happens with our nurse practitioner programs. You also cannot be BRN approved as a nurse practitioner program if you do not have accreditation, right? So those go hand in hand with our nurse practitioner program. With CNSs currently, it's a one-time look at the program, and that is it. That's not something we're able to continue, right? Because we do not have this stuff in regulations. We're looking at what we want to continue as a process and how we can align with the current requirements with these regulations that we're putting forward. So it would be, if you want to continue a method 1 licensure, it would have to have BRN approval. You could defer that BRN approval to an accrediting body, and we can work it very similar as we do with our nurse practitioners. It does require a routine review, on-site visits, etc. But you would be able to maintain a method 1. If you did not choose a BRN approval process, you would lose the ability to have a method 1 because there would be no BRN academia approval.
yeah.
I also
And
have
one
a
of-
question. Oh, so go ahead, Lisa.
No,
No, go.
because one of the problems when is the lack of some national exams for CNSs,
Correct.
and the disappearing national exams. So if we didn't at least have the educational program, we'd have nothing for those people. So yeah,
So I'll provide a little clarification on that, Alyssa.
okay.
So the same as with our nurse practitioners. With our nurse practitioners, there were several exams that retired prior to 2017.
Mm-hmm.
Those exams are no longer current exams, but those people who obtained those and maintained them continue to be licensed in California. That would not change for the CNSs, right? So anybody that has a national certification currently would be able to maintain those, even if, say, a certifying body decides to no longer offer those. We do have the ability to put it into law that if you have license, you're able to maintain license regardless of whether your certifying exam administrator retires that license or becomes a legacy certification. The current CNS programs only only are able to offer programs at a population focus that can obtain national certification. So their primary focuses right now are, I believe, trying to get this right, adult geri, neonatal, and pediatric. And those are the only ones that are currently recognized. So all of our California-based programs offer those three, one of those three, or all of those three programs in California, because with the federal laws, you have to look at the ability to license your students outside of California, especially if they're distance learning education, right? If they offer that. So they would be able to license in other states. All other states require national certification, right? So all of our schools have that primary function already set into them. There is a huge push for women's health CNSs. That is a subspecialty currently, right? It is a population focus, but because there's not a national certification for that, a person that takes a CNS program would originally have to get educated through the adult geri and then do a subspecialty track to wrap in their women's health. And we have two programs currently right now in California doing that option, offering those to students. And those students are able to be licensed in California as adult geri CNSs. They're also able to be licensed outside of California and throughout the nation under that same method with a specialty certification in women's health, so they can still get those jobs and are employed in women's health. And that's something that can be maintained regardless of national certification if they choose to add an women's health. We're always hoping that, the national certifying bodies decide to take that back up and include that. The same with yours, Alyssa, as we know that you're a psychiatric clinical nurse specialist, and that is a track that is not offered any longer through the national board certifying bodies. And so that is not a population focus that is supported for new licensure. That can be completed again through offering an adult geri track, and so that you can obtain national certification and then doing a subspecialty of psychiatric. We have an example of that we use right now with oncology CNSs, that we have a California-based school that offers that. They do a dual track, it's adult geri, you get your adult geri and your oncology at the same time at graduation.
Yeah.
So the CNS programs are finding ways around that. And they're doing a great job working within the limitations of their national board certifying bodies. There was conversation out there that I had heard, and I know that we have some presentations later in this meeting where they are looking at the adult geri national certification and the pediatric certification, seeing if those could be combined to then work with the family national certification, so that again, that category could come back. So I don't know where the national board certifying bodies are going to take us. I know that we at a national level through the APRN consensus model that you guys were talking and referring to only license on the ability to become nationally certified. Currently, that is only 3. We would like to broaden it out to be very similar to the nurse practitioners where it's up to 6, knowing that there is a need for family, for women's, and for psychiatric, and that would be fantastic. The ones that currently have those with the prior national board certifying exam abilities are grandfathered in and allowed to continue with that. So even if you guys chose to move forward with requiring your academic institutions to become certified and to become BRN approved, it would not affect those legacy certifications.
Right.
So to piggyback off of that, if the decision was to, like the CRNAs, require just national certification for everybody and not have the BRN academia approval and remove method 1, can we do like a grandfather legacy, right, clause of some sort for people who have CNS licensure currently?
Yes,
To maintain.
absolutely. there is a section within statute right now that talks about what happened with the nurse practitioners. And I believe it was in 2008. Prior to 2008, if I'm remembering right, I can pull up and double check. There was no requirement for a graduate degree to be licensed as a nurse practitioner. So there could be nurse practitioners in California that would not have a graduate degree and ultimately would not even have board certification because that is a current requirement right now to obtain board certification is at minimum master's degree. So with those statements in our law, we could bring some of those statements forward in regulatory language if we have authority. If not, we would always have to ask for an author to maybe move it through the legislative process to see about that. But the goal is to increase licensure, not decrease licensure. And we would never want to see people that previously were able to be licensed in California that would no longer be able to be licensed in California. So we have a statement here in the Nurse Practitioners Code that says on or after January 1, 2008, an applicant for initial qualification or certification as a nurse practitioner shall meet these qualifications, right? But so we could, if we put these regulatory changes forward, make a statement that says, you know, on or after this person, they meet this for initial, and then we address renewals in a separate section, right?
Yeah.
Because renewals would just be to continue the licensure that you already have here.
It's just a little different. I mean, we've always required a graduate degree, and so we didn't have that problem. But it's just sad because, you know, some of the essence of the clinical nurse specialist is that specialty, and
It is.
you know, they're like fitting, you know, square pegs into round holes to make it work. But I'm, I'm still fighting for that. So we'll go ahead.
Come on,
But
national
I think we-
organization. Hear Alyssa's
Yeah.
plea.
I think right now it just looks like we should keep some educational
Approved.
option there.
Yeah,
Yeah.
and we're happy to move forward with that. And you guys have submitted the regulations with that. I wanted to kind of just get a feeling from you guys how far you wanted me to pursue that, because we will obviously, when it gets to the point where it goes for board committee approval and board approval, then it does go forward and we do post, and then we do start receiving feedback on that. And there may be people that oppose that, and we would need to have a clear understanding come out of this group as well as with our board that that's something that you guys did want to pursue, because then that is how we would respond to all of those comments that came in. So
Yeah.
appreciate the conversation, and we're still working through all of these kind of questions as they come up.
Perfect. Yeah, I think we as the subcommittee will keep working offline and discuss
Right.
this information you provided us.
Yes.
Thank you.
Right.
Sounds great.
Thank you. Thank you.
And I just want to ask real quick, we're going to talk more about the regs in our next agenda item, right? Before I do my report out.
I'm peeking at the next agenda item. You're bumping ahead of me. Yes, we will
Okay.
talk more about them. Yes.
Okay. All right. I just wanted
Yep.
to make sure.
Thank
Okay.
you.
So regulations, that was just your report out?
Yeah.
Okay. So I will report out on public engagement and website. So I have been reviewing. What I started to review most recently has been the clinical nurse specialist programs and schools, which actually goes along with what you guys were just discussing. And so I'm making a new chart that I will send to our group, to kind of make some addendums, but there has been some changes just based on what it says on our board page, but it also does say that the board does not approve clinical nurse specialist programs. And so, so that's what I've been working on the past couple of months, and moving forward to kind of reorganize that a little bit.
By yourself.
Yes,
Right.
and hopefully, yes, moving forward, we'll get some ones.
Thank you.
Mhm.
Just to give you an update, Jessica, when I was looking at the regulatory updates, I did go on to NACNS, and I noticed that the programs and the specialties that they have listed don't match ours. So I did send our current list to our nursing education consultant group. They reached out to the schools that they communicate with to vet that the national website is correct, or if our board website is correct. We're pending feedback from the schools that we reached out to, and based on that, we will update our board website on that for which programs our current California-based schools are offering and which tracks. So that is kind of happening simultaneously to you, only
Great.
because I happened to run across it when I was reviewing the regs that Marissa had submitted over to me for review.
Great.
So just wanted to kind of put that out there that we're working on that as well.
Okay.
If you guys run into anything else that you see on our web that is CNS specific that's outdated, please let us know. We are really working diligently to kind of clean up our website. As I use the website every day, if I run across something that I see as outdated, I immediately try to get it pulled, but I can't do that all alone. And so I really do appreciate the feedback that you guys provide. So if you also see something that could benefit, I would love to hear that as well. And then we can work to getting those added.
Yes. Thank you.
Thank you.
Welcome.
Okay. And so now we can move out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Cheryl Goldfarb Greenwood would like to make a comment. 1 second, please.
I'm a clinical nurse specialist with many years of service in California. I was also a past president of the California Association of Clinical Nurse Specialists, and I'd like to comment on the proposed regulations of which I was one of the members of our committee who authored the original document. I'd like for the advisory committee to take into account that the California Business and Professional Codes 850 and 851 prohibit any board part of DCA from requiring certification by associations or professional societies. So I think it's important to include a review of those regulations that already exist when moving forward with any changes in regulation or any proposed changes to the CNS's obtaining the CNS certificate. For example, eliminating option 1 for the CNS certificate by the BRN, I believe, could create barriers to patient access to CNSs. CNS numbers have declined significantly over the last many years. I have personally collected data from the BRN website since 2015. At that time, there were over 3,500 clinical nurse specialists, and now we are down to a little over 3,000. And I would say that it's very important to keep option 1 so that CNS students have the option to use their academic education as a means to obtain their CNS certificate from the California BRN. I want to thank the members of the CNS Advisory Committee for their hard and diligent work on this very important process that needs to happen for access to care for clinical nurse specialists to survive and thrive in California. Thank you.
And just to put out to the committee in response to that comment, just so that we're all on the same page here. Method 1 that is currently being offered to the CNSs is not codified in statute or regulations. And so that is a process that's being done that we're trying to put into regs. That's the purpose of doing this, is we have no application right now that's in regs. We have no ability to properly obtain licensure for CNSs currently in regs or statute. So that is the process that we're going through. So if we do move forward with a method 1, understand that the Office of Administrative Law, as we say that we want them to have an ability to be licensed through method 1. Method 1 is a BRN approved program. We will have to, in regulations, define what a BRN approved program is and what are the requirements for that. So that will then change the way that we interact with CNS academia moving forward. And so that was the entire conversation. It was not to say, do not do method 1. It was saying, if we continue with method 1, we will have to provide further clarification and guidance in order to meet the regulatory ask. We could not put forward to the Office of Administrative Law, we will license on BRN approval for CNS programs, and then not define what that is. So just so you know that is something that will have to take place if you guys choose to move forward with a method 1. If you choose to not move forward with method 1 and go to national certification, we then would still have to define what that national certification is, the process for that, and then move forward with that, because that is the requirements that Office of Administrative Law ask us to provide clarity and guidance and not leave it up for kind of a guess.
Thank you for your comment. Sorry, Committee Chair Lightcap, there are no other public requests for comments on the WebEx. We have no public requests for comments in our hearing room in HQ1. Would you like me to close this window?
Jessica, I think he's asking for your
Sorry, I forgot
feedback.
I muted myself when Cheryl was talking. Yes, please close the window. Sorry. Okay, moving on to item number 6.0, discussion and possible action regarding the proposed draft regulatory language for clinical nurse specialists, including but not limited to definitions, application process, and education oversight.
And so, Carrie, I think that's where you would kind of continue with your overview.
I was like, I said everything I wanted to say.
You did. You can refer them to this section of the materials if that is helpful. And I could help you with that as well. So on your documents that are in your packet, the language that was put forth that was mentioned by the public commenter as well as our members here begin on page 15. And you can follow that through to page 22. Understanding that these are unedited regulation language that was submitted by the subcommittee. So this is the language before the chief of legislation, Marissa, or myself have had a chance to edit or do anything, review that, tie it back. And the DCA regulatory attorney has not taken a look or opined on these as well. So this is a raw document for you guys to kind of share through that. And if you wanted to, you could again open up to public comment because you have already started that conversation and see if there, excuse me, if there's further interest from the public to get any additional information on pages 15 through 22.
Can I actually ask a couple of questions too?
Yeah, totally.
Okay. So Carrie and Alyssa, when I was looking at these, so first, we mentioned about how we don't have that board approval process yet. And so when I was looking at how, what we're including as far as how to become approved by the board in here, I just have a couple of questions. So first it was mentioning that the director needed to be a clinical nurse specialist and have a license from the board as a clinical nurse specialist. And I was just wondering if we had an idea of how many, master's programs or CNS programs were, already had directors that were clinical nurse specialists and what the impact would be for the schools.
My understanding was that all current CNS programs do have a CNS that is in the leadership role. I could vet that through my NECs, but I don't believe that there is any program that has a person over their CNS program that doesn't have a CNS certificate. There are some combination programs where you get an NP and a CNS at the same time. Because there is a lot of duplicate preparation. And I have seen even in those cases that it is a nurse practitioner who also has a CNS that is in charge or has the direction of that program.
Okay. I had another question too, under 1497 categories of clinical nurse specialists, letter D. It says a clinical nurse specialist may practice in any clinical practice setting or practice area regardless of category or certification by one of the member organizations of the National Commission on Certifying Agencies. And so I'm just asking for a little more clarification on that. Like, does that mean that you could be a pediatric CNS but then practice as an adult CNS? Like, what does that mean? Oh, you're muted.
Oh, Alyssa, you can back me up on this, but yes, that's how I read it.
Yeah, but yeah, I think some of this we really, looked at the NP things, but I think we also, was to allow them to work in different clinical practice settings, more so than, being held out to be an expert in a specialty they weren't an expert in.
Right. I see it as an example as, I get my CNS in adult gero, right? And then my heart is telling me I want to work with kids, right? And so maybe I transfer over to our children's hospital and can still work as a CNS, but don't have to have the CNS pediatric certification.
Okay.
I
makes
think
sense.
Wonder.
I'm sorry. This is one of the ones that's kind of sticky.
Yeah.
Yeah.
I wonder like if that, just because if I ever, like I've only done pediatrics my whole career. And if I was like, hey, let me go take care of adults now, I wouldn't call myself a clinical nurse specialist. I wouldn't know where to start. So I do think this is a little sticky area. I almost wonder if that was more intended, like if you were doing, say, a family tract where you were both educated in both and, then wanting to just do one, like, would that still apply? So I wonder if that's what.
Yeah, I guess my concern with not having that would be limiting your ability to practice, right? Like, so then it would be requiring people if you want to change and do a little something different in nursing, because that's what's lovely about nursing, right? Like we can kind of put our hands into everything, do this for a little while, go do that for a little while, right? And get some different experiences. But then to require that you have to be nationally certified in all of those things that you want to go to would, I think, prohibit people from being able to. That's just
Yeah, and I think one of the other areas is the lack of, certification. So I think this is an area we need to look at the language a little more clearly, and hopefully people will send some more ideas on that. But I agree. I think it allows us to do some different things. But yeah, I would have some concerns about someone coming into psych mental health, let's say, with no background in that. But let's say they were a pediatric person and we had pediatric psych mental health. Or I know a geriatric CNS who's working in geropsych now, but did not really go through psych, but got some extra work, in order to do that. So yeah, I think it's an area we should look at the language again. Thank you.
And then I just had, it's kind of similar to the
So
language
before
under,
you before you
Okay.
move on, Jessica, if I could jump in on this topic so that it doesn't get lost, and then that there are a couple things to consider with this is with your general RN, you are able to work in any specialty as long as you're competent, right? So we err on the side of being competency based, right? So you are educated as an RN as a generalist, and then you're able to go to any specialty area you want as long as you're competent. The board doesn't specifically define what those individual competencies are. We talk about the nursing process as a competence, et cetera, and we go through that. But the employers are really the ones that define that competency section. When we look at, again, the part of nursing that is very similar to you guys, that we do have regulations on, right? And that is our nurse practitioners. So our nurse practitioners, you might have a person that is educated as a pediatric nurse practitioner, and they might be board certified as a pediatric nurse practitioner, but they are working in an adult like liver GI center, right? And they don't even see pediatric patients at all, but they are competent in that role and are able to do that. That is not something the BRN says you can or cannot do. That is employment based. And if you have an employer that is willing to employ you under that and then ensure that you're competent in that with either your standardized procedures or whatever process that they want to follow for that, that is something that has historically been allowable. Even when we looked at moving to the 103 and the 104 NP. The 103 NP, the original interpretation of that, and moving through the introduction and implementation of AB 890 was that it was specialty specific. The most recent legislative process that just occurred removed that education specific and national certification specificity. So now as a 103 NP, you can practice in any practice area, regardless of your national certification or your academic preparation in those specialty areas. That is not changed for your 104 NP. That is a whole separate category, and that has maintained. But the 103 nurse practitioner, because they are working in a group setting, because they have a bunch of resources, because they are kind of defined and limited by their where they work versus what they do, that is something that is supported within the community. Again, especially, and as Alyssa pointed out, your legacy and retired certification, that's a big deal, because those areas don't necessarily exist as much anymore, or they don't have certifying exams that follow that. One of the other things that I want to point out when talking about national certification is through the consensus model. As regulators throughout the nation, we are only able to regulate the population focus. We are not able to regulate the specialties. So if you have an oncology CNS, if you have cardiology CNS, an orthopedic CNS, etc. Those are subspecialties, and because there's not a defined standard of how you obtain those specialty certifications, we as a nation do not regulate those. And so it doesn't prohibit those from continuing or maintaining. It just, we don't regulate those because there's not a standard to vet the quality of that preparation and ongoing maintenance of that.
You're muted, Elisa.
Muted because the dog was talking. I to that point, I just, for psych mental health, that is a population focus. So it is rather sad that there's not a certification because, sometimes nursing speaks out of both sides of our mouth. So hopefully, I'm going to fight that. But I mean, it is a population focus and it is listed as. So, but I still think we should, we'll look at that language and welcome other suggestions for it.
And then just one other comment that I had from reading through this. When you guys were writing about the requirements of clinical preceptors, I kind of look at this in a number of different ways because I also precept a lot of clinical nurse specialist students. And when I became a CNS myself, like my program was out of state and I had a really tough time finding clinical nurse specialist preceptors. And so I wonder when we're looking at the regulations, like if we only, I think there should be some, I don't want to say like wiggle room, but like, I don't know what to, like maybe there's other avenues for someone to be precepted by other people besides clinical nurse specialists, but maybe who have like a clinical nurse specialist who oversees their preceptorship, but then they have different experiences or whatever, like just to make it be easier for the students and the schools to find preceptors.
I would say, like Lori mentioned, we want more more advanced practice nurses, not less. And I precepted NPs. So, I think you're right. We don't want to prohibit something that, is valuable. Just we need to look at that language. Yeah. And I think make it clear that some things will be okay, but, still have some standards.
So I was a little, I guess, confused trying to follow that. So you're saying clinical preceptors do not need to be a CNS to precept for a CNS program.
What I'm saying is that I don't think that, like maybe, I don't know if there's maybe other states can weigh in on what they do, or maybe we can ask our national CNS association to see what other places do too, because if it's only a CNS who's able to precept the entire time, then that's where you run into like, you have a number of different, like say peds CNS students, but there's only like 3 preceptors, and you can't precept everybody.
Yeah, agreed. I agree. I just was, don't know where we specifically called that out under that section under A. On line 295, it's just hold an active, valid California license to practice his or her respective profession and demonstrate current clinical competence. If applicable, have an advanced degree in their content area and demonstrate current competence. So to me, I read that as an advanced degree, right? Your NP, your CNRA, CNM, trying to get all the acronyms right? Would be, I don't think, unless I missed a piece, I don't think it specifically calls out that it has to be a CNS, but it does specifically call out that they do have to have an advanced degree.
Yeah, I mean, I was just saying, like, if you're rewording it, I don't remember it said, I know it said the director needed to be a CNS, board certified as a CNS. But No, I was just saying, like, if there was verbiage in there that said, you know, a CNS student or the preceptor could be another type of advanced practice nurse, or could be, you know, like, just to give it a little more guidance for, because I had people tell me, oh, well, I have a CNS license, but I'm not practicing as a CNS right now, so I can't precept you, you know, because I
Oh.
practice as a nurse practitioner now. Or, you know what I mean? Like, just to make it a little bit less, I don't know, restrictive.
And look at that. I mean, and we also had, if you don't mind, we had questions about some of the titles that the schools had to have for their programs. And I don't know enough, you know, I think that was looked into too. And I think when it's reviewed again, they'll look, because they're, you know, it's very prescriptive in terms of what they should be called. And I don't know that every school calls everybody, you know, director of CNS programs or that kind of thing. So, yeah.
I'll give you some guidance on that one there. So the BRN
Yeah.
has a standard language so that we can standardize across programs.
Great.
What they do with that at the school level is different. So
Right.
an example with pre-licensure is we have people that we approve as a director of nursing, and they meet all of our qualifications to be a director of nursing, and our nursing education consultants work with the directors of nursing for each one of the programs. On their title at school, they're called a dean, or they're called a chair, or they're called something else. So we don't get involved with what they want to call them during their employment. But for standardizations for us, we use a singular term. And so we would stick with the term, the director of the CNS program, and leave it at that. And that the academic institution wants to use a different term other than director of the CNS program, but it fits that same one. We just ask for a duty statement or a job description, et cetera, just to vet that it meets the qualifications.
Thank you.
Thanks for doing all this work, and for the people who did this work previously. I mean, it's a lot.
Thank you for the public comment, Rachel.
Okay. Anything, Carrie or Alyssa, you want to add to this before we move out to public comment again?
Not for me. It's in the materials. I appreciate your questions and your review of it, Chair Lightcap. Thank you very much. Those are good questions.
I do too. Thank you.
You're welcome. Okay, we can move out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no public requests for comments in person in our HU1 hearing room. Would you like me to close this window?
Yes, please, thanks. Okay, moving on to item number 7.0, information only, explanation of the term clinical nurse specialist and explanation of the role and positions within the healthcare systems. And so I am actually presenting this topic. If you can please pull up the PowerPoint, thank you. Okay.
Real quick, Jessica, before you start, is this
Mhm.
also the one where we have a person that will be presenting with you? Do we need to
No,
elevate
next.
them? Next one. Okay, thank you.
Next one. Yeah.
Perfect.
Okay. Clinical nurse specialist, title protection. Next slide, please. Okay, so as we all know, a clinical nurse specialist is one of the 4 types of an advanced practice registered nurse. And the other 3 types are nurse practitioners, certified nurse midwives, and certified registered nurse anesthetists. From the NACNS, they define a CNS as an APRN prepared by a master's, doctoral, or postgraduate certificate level CNS program. CNSs can diagnose, prescribe, and treat patients and specialty populations across the continuum of care. And they improve outcomes by providing direct patient care, leading evidence-based practice, optimizing organizational systems, and advancing nursing practice. Within the healthcare system, the clinical nurse specialists are either in roles that are called clinical nurse specialists, or they could be doing a wide variety of other things as well under their clinical nurse specialist licensure. And so CNSs are often referred to as the innovators in practice, as constant mentors for nurses and other interdisciplinary team members, as coordinators and collaborators in patient care. They're often seen as the engineers of healthcare systems and the go-to professionals who understand and know the broader healthcare system. And CNSs help to coordinate care and treatment, and they assist patients, families, and staff to best navigate, negotiate, and work within the healthcare systems and the community. So this moves into why is protecting the title of a clinical nurse specialist important? And it is because sometimes there is role ambiguity as far as calling or people calling themselves clinical nurse specialists that don't actually have the licensure of a clinical nurse specialist within the state. And so sometimes employers are utilizing the title of clinical nurse specialist to describe positions or staff that do not meet the education, certification, or licensure requirements to use that title. And eligibility to be called a clinical nurse specialist requires an active RN license and a graduate or master's degree from an accredited clinical nurse specialist program, like we already been talking about today, that we're trying to, create these regulations to kind of move forward and keep the clinical nurse specialist title protected. Next slide, please. And so I just wanted to further stress that title protection really helps to recognize the clinical nurse specialist's unique role by ensuring healthcare systems have consistent standards for licensure and titling, which qualify the licensed and titled CNS to be utilized to their full scope of practice. And title protection gives guidelines and expectations within a healthcare system for this CNS APRN role. And with these clear and consistent expectations, they contribute to increased patient safety, improved patient outcomes, protocol development, evidence-based practice, and cost savings. And because of title protection, when you're a patient and you have someone called clinical nurse specialist involved in your care, as a patient, you can have confidence that the healthcare organization and the providers treating you possess the appropriate qualifications, training, and expertise necessary to make informed healthcare decisions and help you recover. Okay, next slide, please. There are definitely roles within a healthcare system because of the language that we call a number of different nursing positions. Sometimes they all have the name clinical in them or specialist. And so it can be really confusing when, there are roles not clearly identified as a clinical nurse specialist, or you have someone who, say, is a clinical nurse leader, which is not a type of advanced practice nurse, but they do have a master's in nursing, or someone, for example, like a nurse clinician, again, the name clinician and nurse, or a nurse educator has a different set of, specialties that they work for. And so there is a lot of ambiguity within a clinical nurse specialist, and the hospital systems. And so being very clear with when we're making these regulations and being very clear when we're in our own practices within the hospital systems as far as what a clinical nurse specialist is and what our education and licensure say that we can do. Next slide, please. And not to go into very big details because it's all on the BRN website, and I put some just kind of snips on the next few pages. But if you do see that there's someone who is calling themselves a clinical nurse specialist within a healthcare system, but they are not actually licensed as a clinical nurse specialist, it can, be a little awkward and you might not know what to do. And so this is just a kind of brief overview of how you would approach this or how to get help from the board, which is why they are there to help with these kind of things. So Loretta, I don't know if you want to talk about this a little bit.
Yeah, I definitely can. I could jump in and help you guys out here. So the Business Professions Code 2838 says no person shall advertise or hold himself or herself out as a clinical nurse specialist unless he or she is a nurse licensed under this chapter and meets the standards for clinical nurse specialists established by the board. That is where you started to kind of talk, Jessica, because I think you experienced this in your life outside of being an advisory committee member, where there were people out there saying they were a clinical nurse specialist and they were not licensed in California as a clinical nurse specialist. There are employers that do employ people in these roles that don't meet this title. And in fact, we get a lot of inquiries to our board that says, I'm already doing the job of a clinical nurse specialist. How do I get licensed as a clinical nurse specialist? And that's another reason why getting this regulatory language in place and providing clear guidance on licensure is really going to be a benefit to the profession as well as public protection. Because what you were saying is a patient or a family member have an expectation for quality that they can obtain from a person that is appropriately educated and licensed as a clinical nurse specialist and not someone who says, I'm like one. On a personal side note, I used to be one of those people. I worked as a nurse education specialist, and I thought in that role that I would meet the qualifications of a clinical nurse specialist. In my opinion, I was doing the same job. You learn as you move through your profession. And so years later, I now know better. But those are some of the things that you can get some misinterpretation, you get misunderstanding, and really cause not only issues within the profession, but within the public and employers that are trying to utilize people in those positions to really advance healthcare. What I think a lot of people do not understand is that outside of California, these people who hold a title of clinical nurse specialist do diagnose and do prescribe and do carry a patient load in an independent practice setting. That is not something that California supports at this point. If there is legislation later that they would like to expand that scope of practice, that is something that have to go on with the legislator and go through a statutory change. We cannot increase scope of practice through regulation. We can only kind of define scope of practice that's supported in statute, right? So that, I think, is a first step for you guys when you're looking at what do we want to do in California in the future as an organization, as people that carry a license as a clinical nurse specialist. If you're wanting to look at how to bring your full scope of practice to California, and title protection is a beginning part of that, right? If you have people that do not have appropriate education and do not have the 3 Ps, right? then they don't have the advanced assessments, they don't have advanced pharmacology. How could you expect them to be able to prescribe and diagnose, et cetera, et cetera? So this is a common thing that we see within the nursing community as well as with the employer community. And I think it starts here with your guys' attention to this, putting that education out and really just being vigilant on kind of a re-education. This is not far off from what happened with our public health nurses, where the legislators stepped in and wrote into statute that because there was confusion, they wanted to make it very clear that there is a defined role for a public health nurse and that this is what they do. And I think because this is a emerging advanced practice specialty in California that has a potential for growth in scope of practice and utilization, that your guys' role in this advisory committee is right in line with what you're doing right now. So I appreciate that. And yes, filing a complaint is not a negative thing. And so I want to kind of always point that out there, that I know that when I was at the bedside, BRN was kind of used as a threat. Is that BRN is going to take your license, BRN is going to do this, BRN is going to do this. And filing a complaint just means that an investigation can be done and some education can be given. It doesn't always end up in a discipline against a license. It can be a cite and fine. It can be a public reproval. There can be, and public reprovals are considered discipline, sorry, but cite and fine is not. And it could just be a reach out where we can provide education. I know that our DCA, the Department of Consumer Affairs Director, is really kind of encouraging the boards and bureaus under them to try to provide more and more education out to their licensees to ensure that there's not scope of practice issues that come up. And so kind of preemptively getting out ahead of issues versus coming up on the back end side of providing discipline. So we would love to provide education over discipline 100% of the time. And so anytime that we're able to do that and facilitate it, do that. And so you guys in your practice now, this is on our website. So please share it out. This will also be webcast and you guys be able to find it on YouTube later on. Share out the conversation around this so that you can ensure that the employers and the public have the same expectation for a clinical nurse specialist as we do here at the board.
Thank you. This is good because I think this is not only title protection, this is role protection and protection of the public. So you know who's taking care of you. So thank you for that. And I just to share something from the original 1998 group that did a survey of CNSs in the state of California. We had people who thought if they worked for 10 years, they should be called for clinical nurse specialists. They just had no clue about education and what else they needed. So we did some education. Thank you.
Okay. You can go through the slides. Yeah, this just talks about what was on the website.
Thank you.
Okay, that is the end of that. All right. Out to public comment.
Yes, unless there's further discussion from the members.
No, that was a great presentation. Thank you.
Thank you, Jim.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I would like to give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no, we have no requests for comments in our hearing room in HQ1. Would you like me to close this window?
Yes, thanks. Okay, moving on to agenda item 8.0, information only, presentation from California Association of Clinical Nurse Specialists on future priorities for CNSs, including national certification exams.
Thank you. And board
Okay.
moderator, can you please elevate Olena in the from the attendees, please? Thank you. And Olena, can we do a mic and video check to make sure that you're able to see and hear? Elena, you may not have video, but we do see that you have an audio. You're currently on mute. Are you able to unmute and check to ensure that you're able to assist in the presentation with Alyssa? We are not hearing from
there she goes.
Elena. Okay. Elena, I see you. There you go. Then are you able to speak so we can text your audio?
Hello?
Yes. Perfect. Thank you. Okay,
Great.
we'll turn it over to Alyssa.
Okay, I'd like to introduce Elena Svetlov, who is our president-elect for California Association of CNSs. She's really going to be talking more about an update on our journey toward full practice authority. I'm not sure we'll get into national certification exams right now. Elena and Pam Nye, who is our past president, we're both going to speak, but Pam is one of the people who lost her home in the fires. And Elena has been affected through evacuations and loss of power. And I just want to say a word for anybody who's in the midst of that or has friends or colleagues, you know, that we're with you and hope for the best. And I think the winds are finally letting up a bit and hope for a good recovery. So, Elena.
Yes, good afternoon, everyone. And Alyssa, thank you so much for taking a moment and really acknowledge all the volunteers, donation, love, and care that many of us receive here in Los Angeles. And it is so unfortunate that past President Pam J. Nye literally lost everything in the moment in flames. And she is one of the leaders on not only in California, but on a national level, who dedicated all her life. She doesn't have kids. She doesn't have that much of a family except her husband and little puppy, Cooper. And she dedicated herself to nursing profession, advocacy to the CNS, and knowing that everything that she developed is actually gone and she needs to restore anything that is, you know, in a digital format, but the books and writings and manuscripts are all gone. So thank you. If you do know her, maybe we can share her email and you can contact her. So it will mean a lot to her. We're really grateful for giving us an opportunity today to present Alyssa and I reporting on behalf of California Association of Clinical Nurse Specialists Legislative Regulatory Committee, and as we continue work on achieving a full practice authority for clinical nurse specialists here in California. To clarify, full practice authority permits nurses, including advanced practice nurses, that they are, you know, to fully practice to what the education and the training allow us to do. With the full practice authority, clinical nurse specialists specifically can practice within their scope, legally and fully able to, you know, as what is prescribed in the National Apparent Consensus Model from 2020 to 2030 Future of Nursing Report. That's a whole, it's not only for California CNSs, but actually encompassing the practice across the nation. We really believe that we can improve access to the expert care for the public if we have CNSs advocate full practice authority. As our past president notice that we're actually going down with our numbers at the CNSs, but together we are the largest state that we have amount of 3,000 clinical nurse specialists here in California. We are the strongest power here, and yet we don't have a full practice of authority. So of course we're trying to get our model from Minnesota and what CNS has accomplished over there, but all the states surrounding the California, like Oregon, Nevada, Arizona, even Washington, if you go up, they all have full practice of authority. So we're really striving from that. This reflects national standards and efforts to remove barriers for all advanced practice nurses, including clinical nurse specialists. So as a California CNS Association, we are working with our legislatures. We identify legislatures in the areas. In our meetings, we promote having conversations with our senators, with our legislatures who can actually have a relationship with us, know who we are, have our role, our visibility, and making sure they understand what we do on organizational levels. We're working on a program to educate public about the value of CNSs to the healthcare throughout our regional events on the Northern California and Southern California, through creating a student forum and developing relationship with the clinical nurses across the spectrum of California, plus connecting with the leaders of organization like chief nursing officers, executives, and CNOs of the hospitals. We are trying to promote and elevate the CNS role. Using the platform LinkedIn to making the visibility, sharing our posts through the entire platforms across the nation and California. We believe that full practice of authority for CNSs will improve healthcare in California by, and I'm going to read, we have a list here, that increasing access to care, including for underserved communities and vulnerable patient population, reducing delays in receiving care and treatment to add to the workforce. So many examples, like today I'm rounding on my patients, and where the rounds are already conducted with my physicians, magnesium level is a little bit low. There's a nurse practitioner because she's rounding on the other patients, and I'm here like following up the rounds with the clinical expertise that I can provide for my cardiac surgery patients. I could easily get that going. Or there is a discharge going on, and they're delaying on the durable equipment, and I can go ahead and do this order there too. So currently we don't have that capability to do it. We can provide a coordinated comprehensive care treatment for patient and family, education and consultation. We can enhance patient healthcare outcomes with the individualized patient care approach. As a CNSs, we often ask to see the most complex patients when we go provide the consultation, and we can bill for those consultations and help the organizations to get the patients get a better outcome. We can improve continuity of care for patients, especially with those with complex and chronic conditions. We can follow up, implementing leading evidence-based practices, and lead the research and help the organization in acute care settings and ambulatory care settings. With that, we would like to say that we are grateful for Clinical Nurse Specialist Advisory Board for all the amazing work and advocacy that you do for us. And we're looking forward to partner and share what we do. One of the examples is that Pam J9 initiated and led a speaker bureau where the CNSs across California provide their addresses, emails, and contact information and topics, what they can support the schools for the CNSs or preceptorship, and identify who would like to precept and what area they would like to precept. So currently it's available online for California CNS Nursing Network website. So we are looking forward to share this with you. So maybe it will help on a national level and here in California level for anybody who needs a preceptor will be able to join us and get the best experience from the CNS possible. Again, thank you so much for allowing us to present today. Looking forward for any collaborations in the future.
Thank you, Elena. I'm so lucky, I guess, and privileged to know you and to be part of our organization and part of this group. So thank you.
Thank you.
Elena.
Thank you very much. I would like to, are there any other comments from committee members? Okay. I would like to bring it out to public comment now.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no public requests for comments in person in HQ1 in our hearing room. Would you like me to close this window?
Yes, please. Thanks. Okay. Moving on to adjournment.
Thank you. It is 2:25 and agenda item 9.0 is adjournment. And so at this point, thank you guys. Enjoy the rest of your day. We will end this meeting.
Thank
Thanks,
you.
everybody. Thanks for all the work everyone's
Thank you,
doing.
everyone.
Bye.
Yes, thank you. Thanks, Jessica, Carrie,
Bye.
Laurie, everybody. Thank you.
Thank you so much. Bye-bye.
Bye-bye.